Okay, let's unpack this. We're about to go on a journey today, moving from understanding the fundamental physics of brachytherapy sources, how radiation interacts with matter, dose fall-off, to how these concepts actually translate into treating a patient.
Right.
Think of this as bridging the gap between the physics equations and the clinical application.
That's right. We've previously discussed the sources themselves, their decay characteristics, the inverse square law, all that fundamental stuff.
Yeah.
Now, the real challenge in brachytherapy is taking multiple sources, arranging them precisely within or next to a tumor, and delivering a prescribed dose while sparing healthy tissue. It's complex. This involves specific techniques, historical planning systems we need to understand, and crucial dose reporting concepts.
And that's our mission today, to explore the practical side. How do we place sources in cavities versus directly in tissue? What were the foundational rules developed before powerful computers?
Before everything was just, push-button optimization.
Exactly. What do specific dose points, like those famous ones in gynecology, actually tell us? And why does the speed at which we deliver the dose rate, have such profound implications? This is where the physics meets the patient.
Absolutely. Let's jump right into the applications, starting with intracavitary brachytherapy. As the name suggests, this involves placing radioactive sources inside applicators within natural body cavities.
Okay, intracavitary, inside cavities. Makes sense.
Simple enough concept, but powerful.
And the prime example, the one you'll encounter most often, is in the treatment of gynecological cancers, specifically cervical and endometrial cancers.
Definitely.
It's a cornerstone of treatment for these sites, isn't it?
Precisely. For gynecological cases, specialized applicators are used to hold the sources in reproducible geometric arrangements relative to the target anatomy.
Ah, so these applicators are key for consistency.
Critical. The most common design involves a central tandem, which is a slender tube or rod inserted into the uterine cavity and cervical canal.
Okay, the tandem goes up the middle.
Right. And then lateral components that sit against the cervix in the vaginal fornices, those little spaces up top in the vagina.
Gotcha.
These lateral components can be ovoids, which are sort of egg-shaped caps, or sometimes a ring structure.
So the tandem goes up into the uterus, and the ovoids or rings sit down below, surrounding the cervix and the vagina. Is that the idea?
Exactly. The tandem positions sources along the axis of the uterus and cervix, while the ovoids or ring position sources laterally, sort of wrapping around the cervix.
And then these applicators themselves, they aren't radioactive.
No. They're made of inert materials like plastic or metal. They aren't radioactive themselves. Their sole purpose is to provide a rigid framework. They hold things in place.
Okay.
To precisely position the radioactive sources, or, in modern systems, the guide tubes through which the sources are delivered remotely.
And the sources used have really changed over time, haven't they? I mean, dramatically.
Dramatically is the right word. Historically, low dose rate, or LDR, sources were the standard, predominantly cesium-137.
Cesium, right. I remember hearing about that.
Yeah. Cesium-137 has a relatively long half-life, about 30 years, and emits gamma rays with an energy of around 662 kilo-electron-volts, 662 keV.
So pretty penetrating gamma rays.
Yes. And placing these sources manually into the tandem and ovoids meant the patient had to remain hospitalized, often in a shielded room, for several days.
Days. Wow.
Yeah, while the treatment was delivered continuously at a low dose rate, staff had to observe strict radiation precautions when interacting with the patient. Time, distance, shielding.
That sounds logistically really challenging for everyone involved.
It was, and that's where high dose rate, or HDR, really revolutionized things.
Okay, HDR. This is what we mostly see now, right?
But predominantly, yes. The shift to HDR primarily uses iridium-192 sources. These are typically tiny sources with very high Air Kerma strengths, used in remote afterloading systems.
Remote afterloading, meaning the source isn't put in manually.
Correct. The iridium-192 source is stored in a shielded device, like a safe, and it's mechanically or electronically driven through cables into the applicator, dwells specific positions within the tandem and ovoids according to a computer-controlled plan.
Ah, computer control. Much more precise, I imagine.
And much faster. This allows the treatment to be delivered in just minutes per fraction.
Minutes versus days. Huge difference.
Huge. The patient doesn't require hospitalization for the treatment itself, usually outpatient. And crucially, staff are not exposed to radiation during the treatment delivery because they are outside the shielded room while the source is out.
That's a major safety improvement, too.
Absolutely. So the shift from LDR cesium to HDR iridium wasn't just about the source, but the whole delivery mechanism and patient care model. It changed everything.
Okay, but regardless of LDR or HDR or which source you use, you still need a way to specify and report the dose delivered, right? You need some common language.
Absolutely. And before the advent of powerful 3D computer planning that could calculate dose basically anywhere, this was a significant challenge.
Yeah.
How do you describe what you did and what dose you gave?
Yeah, how did they do that consistently?
This is where historical standardization efforts became essential, leading to reports like the International Commission on Radiation Units and Measurements, or ICRU Report 38.
ICRU 38. Ah, yes. This report is famous, or maybe infamous for physics residents, for defining specific reference points in gynecological brachytherapy. Why are these points so important?
They were critical for standardizing reporting. Absolutely critical. They allowed comparison of clinical outcomes between institutions and different techniques, even with limited planning capabilities, like just using orthogonal X-rays.
So it provided a common language.
Exactly.
Yep.
A common language and a few key metrics to gauge the treatment, even if you couldn't see the whole 3D dose picture like we can now.
Let's dive deep into those points then. First, point A. How is it defined? What's the classic definition?
Okay. Point A is classically defined based on the geometry of the applicator. You locate the external cervical os, that's the opening of the cervix you can see, or if the tandem has a flange, like a little collar that sits against the cervix, you measure from the superior surface of that flange.
Okay, so from the os or the flange.
Right. From either the os or the flange, point A is defined as being 2 centimeters superior, which means upwards along the axis of the tandem.
2 centimeters up. Got it.
And D, it's simultaneously 2 centimeters lateral, measured perpendicular to the central tandem.
Ah, okay, so 2 centimeters up from the os or flange and 2 centimeters out to the side from the tandem itself. That second dimension is crucial, isn't it?
It is 2 centimeters superior and 2 centimeters lateral. Now, clinically, point A was chosen because it was thought to represent the dose to the parametrium.
The parametrium, that's the tissue next to the cervix.
Exactly. The connective tissue and fat lateral to the cervix in a critical region. This region is where the uterine artery and vein cross over the ureter, about 2 centimeters lateral to the cervix.
Ah, the ureter crossing point. That's
Yeah.
vital anatomy.
Extremely vital. It's a high-risk area for tumor extension and where local control is paramount. So point A was intended as a surrogate, like a stand-in, for the dose delivered to that vital parametrial tissue near the ureter.
Okay, so it's a geometric definition meant to approximate a critical anatomical location. And a key feature of point A, something that trips people up, is how it relates to applicator movement. Can you clarify that?
Yes, this is a defining characteristic and often a point of confusion. Point A is defined relative to the applicator's position. Specifically, it's tied to the central tandem, meaning if the tandem shifts position within the pelvis, maybe the patient moves or the packing shifts, point A shifts right along with it.
Ah,
It's like a point painted onto the applicator. Wherever the applicator goes, point A follows. This is because its definition relies on distances from the applicator itself, 2 up, 2 over from the tandem.
okay, that's a really important concept. Point A is mobile, moving with the applicator. Got it. Now let's move on to point B. How is point B defined?
Point B is classically defined geometrically as being 3 centimeters lateral to point A.
3 centimeters lateral to point A. Hang on. If point A is already 2 centimeters lateral from the patient's midline, assuming the tandem is centered, point B would be 3 centimeters further lateral from point A, making it.
Correct. If point A is 2 centimeters lateral to the midline, then point B, 3 centimeters lateral to A, ends up being a total of 5 centimeters lateral from the patient's midline.
Okay, 5 centimeters out from the midline. And height-wise?
It's defined at the same superior-inferior level as point A. Same height, just further out.
Okay, 5 centimeters out from the midline at the same height as point A. And clinically, what area does point B represent? What were they trying to estimate there?
Point B was intended to represent the dose to the pelvic sidewall and areas where obturator lymph nodes might be located.
Ah, the lymph nodes further out.
Exactly. It gives an estimate of the dose delivered further out in the pelvis, away from the immediate vicinity of the cervix and uterus, sort of a measure of dose.
And contrasting with point A's mobility, the key feature of point B is, what's the big difference?
Point B is considered fixed relative to the patient's pelvic anatomy. It's defined spatially relative to the patient's midline and bony pelvis, not relative to the applicator.
So unlike point A,
Unlike point A, if the applicator shifts, the physical location of point B in the patient's body doesn't move with the applicator. Point A is fixed relative to the implant. Point B is fixed relative to the patient's anatomy, specifically the pelvis. That's a really important distinction for understanding dose reporting and potential setup variations.
That really clarifies it. Point A is like a spot on the applicator itself, moving with it. Point B is a specific landmark, like a point in space within the patient's pelvis.
Yeah.
Even if the applicator moves, point B stays put relative to the patient.
Excellent way to put it.
Exactly right. Okay. Beyond points A and B, ICRU 38 also addressed dose reporting to critical organs at risk, or OARS, particularly the bladder and rectum. Historically, how were those points determined for dose reporting? This must have been tough.
With LDR and limited imaging, this was quite challenging, yeah. Often, it involved placing contrast material like barium paste or liquid into the rectum.
Oh, like for a barium enema?
Sort of, yeah, just to see the rectal wall. And a Foley catheter balloon inflated with contrast in the bladder.
Okay, so you could see outlines on an X-ray.
Right, and then you take orthogonal radiographs like AP and lateral views with the applicators in place. You would then try to visually estimate the location of the anterior rectal wall and the posterior bladder wall relative to the applicators and calculate the dose to representative points on those surfaces.
Wow, that sounds approximate.
It was prone to significant geometric uncertainty, absolutely. It was a best effort with the tools available at the time.
Thankfully, modern practice is vastly different, right?
Oh, completely different world. With 3D treatment planning systems, we acquire CT scans, sometimes with MRI fusion for better soft tissue definition after the applicator is inserted.
So you see everything in 3D?
Exactly. We contour the full volumes of the bladder, rectum, sigmoid colon, and other relevant OARS. We then calculate the full 3D dose distribution and evaluate the dose to these organs using dose-volume histograms, or DVHs.
DVHs, those graphs showing volume versus dose.
Correct. This gives us a far more accurate and comprehensive picture of OAR dose. We typically report metrics like the maximum dose to a small volume, for instance. D, 2 cubic centimeters, the minimum dose received by the hottest 2 cubic centimeters of the organ. That gives a sense of the peak dose.
That's a massive leap in precision and safety, clearly. But even with DVHs, understanding point A and B is still vital, right? They haven't just disappeared.
Absolutely, for several reasons. First, a vast amount of historical clinical outcome data is reported using point A and B doses. Decades of literature.
Right.
To interpret that literature and understand treatment trends, you must understand what those points represent. You can't compare old studies to new ones without it.
Okay, historical context. What else?
Second, they still serve as useful reference points, even today, for comparing plans quickly or understanding the general dose distribution shape. While modding planning optimizes based on volume goals, looking at the 0.8 dose, for example, remains a quick check on whether sufficient dose is likely reaching the perimetrium. It's linked to the history and a quick sanity check.
So, useful shorthand, even now. Okay, so ICRU 38 recommended reporting wasn't just about A and B then. What else did they suggest reporting?
No, it was more comprehensive. They recommended reporting the source type and strength, the applicator details, tandem length, ovoid size, etc., the dose to point A, point B, and the identified bladder and rectum points.
Okay, the basics.
They also suggested reporting the total air Kerma delivered, which is a measure of the total radiation output over time from the sources, or the total treatment time for the implant.
Gives a sense of the total source oomph.
Exactly. And ideally, reporting the reference treatment volume, often defined as the volume enclosed by a specific isodose line. For instance, the volume enclosed by the isodose line corresponding to the total prescription dose when combined with external beam radiotherapy, like maybe the 60 gray total dose line.
Ah, so describing the volume that got the full dose, that paints a better picture of the whole treated volume. Okay, so that covers intracavitary, with a deep dive into those crucial points for GYN brachytherapy. Now let's shift gears to interstitial brachytherapy.
All right.
This is where we place sources directly into the target tissue, right? Not in a cavity.
Right. Instead of using natural cavities, interstitial brachytherapy involves implanting radioactive sources directly within the tumor or target volume using needles, catheters, or permanent seeds.
Oh.
Think needles going right into the tissue.
And where is this technique used? What are some examples?
Oh, lots of places. Prostate cancer is a huge one with permanent seeds, accelerated partial breast irradiation after lumpectomy, often using catheters, boosts for head and neck cancers, treating sarcomas, various sites where you need to get dose right into the tissue itself.
Okay, and because you're manually positioning individual sources or planning dwell times and catheters within the tissue, achieving a predictable and clinically acceptable dose distribution requires a strategy, right? It's not as constrained as an applicator.
Exactly. You need rules. This is where the historical systems of interstitial brachytherapy come in. They were developed to provide that strategy.
These systems, they sound like rule books.
Essentially, yes. Sets of empirical or semi-empirical rules developed over time, mostly in the pre-computer era, to guide source placement. Things like how many sources, what strength, what spacing, what geometric arrangement, all to try and achieve a desired dose pattern within the implanted volume before sophisticated computer optimization was possible.
Let's explore the classics. First, the Patterson-Parker system, often synonymous with the Manchester system. What was its core goal? What were they trying to achieve?
The primary goal of the Manchester system, developed way back in the radium era in Manchester, UK, was to achieve a uniform dose distribution throughout the implanted volume.
Uniform dose. That sounds ideal.
It was the ideal, yeah. Specifically, to keep the dose within a range of plus or minus 10% around the prescribed dose. So quite tight uniformity.
Okay, uniform dose plus minus 10%. And how did they achieve that uniform dose using this system? What was the method?
This is the clever part, and maybe a bit counterintuitive at first. To achieve a uniform dose distribution, the Manchester system uses non-uniform source loading.
Non-uniform sources to get uniform dose. How does that work?
It means the radioactive sources inserted into the tissue are not all the same strengths or linear activity density, activity per unit length. The rules dictated placing relatively stronger sources or placing them more densely at the periphery of the implant compared to the center.
Okay, stronger sources on the outside, weaker on the inside.
Essentially, yes. Think about it from a physics perspective. The reasoning is rooted in the inverse square law and scattering. At the edge of an implant, a source has less surrounding radioactive material compared to a source in the center.
Right, less stuff around it contributing scatter.
Exactly. Therefore, it receives less dose contribution from scatter originating from other sources, and the dose it contributes falls off rapidly into the surrounding tissue because there's nothing else out there. By placing stronger sources at the edges, for example, at the ends of needles or wires in a planar implant, or on the surface, the rind of a volume implant compared to the interior core, you compensate for that edge effect.
Ah, you boost the dose at the edges where it would naturally be lower.
Precisely. You compensate for the lack of scatter and proximity effects at the boundaries of the implant, and the result is a more uniform dose distribution throughout the entire implanted volume. It levels things out.
So it's all about compensating for the geometry and scatter effects at the edges. What kind of rules did they have? Were they complicated?
Oh yes, the system laid out very specific and detailed rules based on the shape, planar or volume, and size of the implant. These rules dictated the ratios of activity in the periphery versus the core, the optimal spacing between sources or needles typically recommended to be less than or equal to 1 centimeter for good uniformity, and specific guidelines for handling common shapes like rectangles, circles, cylinders, or spheres.
A rule for everything.
Pretty much. For planar implants, like a single plane of needles, the prescription dose was typically specified at a distance of, say, half a centimeter or 1 centimeter from the plane of sources, and the system was best suited for relatively thin targets, maybe around 2.5 centimeters in total thickness.
Okay. And what kind of sources was the system designed for?
It was designed primarily for higher energy gamma emitters like radium cesium-137 or iridium-192, where scatter plays a significant role in the dose distribution. It's less applicable or needs modification for low-energy sources like iodine-125 seeds, where the dose fall-off is dominated by attenuation and the inverse square law very close to the source, and scatter is less widespread.
Okay, so Manchester. Non-uniform sources aiming for uniform dose, compensating for the edges, best for higher energy gammas. Got it. What was the alternative system? You mentioned others.
The main alternative was the Quimby system. This system was conceptually simpler, at least in its approach to source loading.
Simpler how? And what was its goal? Manchester wanted uniform dose.
The Quimby system's goal was primarily to ensure a specified minimum dose was delivered throughout the target volume. It wasn't strictly aiming for dose uniformity like Manchester was. The focus was on hitting that minimum dose level everywhere.
Okay, focus on the minimum dose. And how did it achieve this minimum dose goal? What was the source loading strategy?
By using uniform source loading. Simple as that. All sources within the implant volume had the same strength and were typically spaced relatively uniformly.
Ah, okay. Uniform sources throughout. Much simpler to implement, I guess. But what effect does that have on the dose distribution if everything's uniform strength?
Well, as you might predict, with uniform sources, the dose falls off most rapidly as you move away from any individual source. In the center of a volume implant, You get contribution from all the surrounding sources.
So it adds up in the middle.
Exactly. It leads to a significantly higher dose, a hot spot, right in the center of the implant. At the edges, the dose is lower because there are fewer contributing neighbors. So uniform source loading with Quimby results in a less uniform dose distribution compared to Manchester.
Makes sense.
You typically get a significant dose inhomogeneity, often exceeding 10%, with the center of the implant being noticeably hotter than the periphery where the minimum dose occurs.
Hot center, uniform sources, that's Quimby. How did its efficiency compare to Manchester in terms of, say, total activity needed?
That's an interesting point, because the prescription dose with Quimby is defined by the minimum dose delivered within the volume, which is typically found at the periphery or maybe midway between sources in the coldest spot.
Right, you prescribe to the cold spot.
Yes, and because the center is much hotter, you generally need to use more total activity, more milligram hours for radium, or higher total Air Kerma strength for modern sources with a Quimby system compared to Manchester to achieve the same minimum dose in that coldest spot. You're essentially pushing the minimum dose up, and the central dose rises disproportionately higher along with it. Manchester is generally more efficient in terms of activity used for a given target dose level.
Got it. Manchester, non-uniform source, uniform dose, edge compensation. And Quimby, uniform source, hot center, aiming for minimum dose. And then there's the parasystem. What's the story there?
The parasystem came along a bit later. It was developed primarily for low-dose rate implants using flexible wires, most commonly iridium 192 wires, which became popular after radium.
Ah, for wires, not just needles or seeds.
Exactly. Though its principles have also been adapted for high-dose rate implants using catheters, particularly in sites like breast brachytherapy or gynecological boost, where you have parallel catheters.
So, designed for those linear sources like wires or catheters arranged in parallel, how does it work? Source loading.
The parasystem also uses uniform source loading along the line, similar to Quimby in that sense. The sources, or the dwell positions in HDR, have uniform linear activity or weighting along each line.
Okay, uniform sources again.
Yes, but the key is the arrangement. The sources are arranged along parallel lines or within parallel planes, and these lines or planes are typically spaced equidistantly, meaning the same distance apart. Think parallel tracks.
Uniform sources, parallel lines or planes, equal spacing. Got it.
How is the dose prescribed in the parasystem? This seems to be a key differentiator for these systems.
It is unique to Paris. The dose specification is based on something called the basal dose.
Basal dose, what's that? The basal dose is calculated at specific points located midway between the parallel lines or planes of sources. Imagine drawing a line perpendicular to two adjacent source lines. The basal dose points are on that perpendicular line, halfway between the sources.
Okay, points right in the middle, between the tracks.
Exactly. The prescription dose rate is then defined as 85% of the minimum basal dose rate found along those midpoints between the sources, or sometimes 85% of the average basal dose rate if it varies significantly along the length.
85%. Why 85%? That seems oddly specific.
It does, doesn't it? It's partly empirical, based on clinical experience with wire implants, and partly a way to define a representative dose in the target volume while accounting for the unavoidable lower dose regions that exist directly between parallel lines of sources. Prescribing to 100% of the absolute minimum dose between the lines might lead to significantly over-treating the tissue closer to the lines or require impractically close source spacing. So 85% of the basal dose became the convention.
Okay, so find the points midway between the parallel lines, calculate the dose there, basal dose, find the minimum or average of those, and the prescription is 85% of that value. Uniform lines, 85% of the minimum average basal dose.
You got it. That's the parasystem in a nutshell.
So 3 systems, 3 different strategies to achieve a desired dose distribution from interstitial sources, trying to keep them straight. Manchester, non-uniform sources, uniform dose.
Right, Manchester. Non-uniform sources to get uniform dose. Remember the edge compensation.
Quimby, uniform sources, hot center, aiming for a minimum dose.
Perfect. Quimby, uniform sources resulting in a hot center prescribed to the minimum.
Paris, uniform lines, parallel, 85% of the basal dose between them.
Excellent. Uniform lines of sources, prescription is 85% of the basal dose between them.
MNU, QU, RH, PUB. Okay, maybe that helps. MNU, Manchester, non-uniform sources, uniform dose. QUH, Quimby, uniform sources, hot center. PUB Paris, uniform lines, basal dose at 85%. Saying it like that really helps. It's so easy to mix these up, especially when you're trying to recall the specifics under pressure, like for boards or something.
Oh, absolutely. It could definitely feel like a lot to juggle. Yeah, it reminds me of trying to remember all the details about, say, Bragg peak modifiers or electron beam PDD depths off the top of your head years later.
Sure.
It's the kind of stuff you cram, use for a bit, and then honestly, you rely on software or look it up constantly in practice. It's like that old joke.
Uh-oh, physics joke incoming?
Sort of. How do you make a medical physicist laugh? Show them a perfectly uniform dose distribution because they know it's probably impossible.
Okay, fair.
And how do you make a radiation oncologist laugh? Ask them to draw a Quimby planar implant source configuration from memory a year after their physics boards.
Laughs. Okay, that's painfully true. You appreciate the principles and the history, but the practical application moves to computer optimization pretty quickly.
Exactly. You're not usually sitting there with graph paper and the Manchester rules anymore. But understanding these systems gives you the underlying logic. It's not just trivia.
Yeah.
It's the foundation of how we thought about optimizing interstitial implants for decades. It informs the algorithms used in modern planning, even if we're no longer manually calculating according to strict system rules. Understanding the why behind source placement is still relevant.
Speaking of modern applications that grew out of these principles, let's move to a very common interstitial technique that's widely used today: permanent seed implants, specifically low-dose rate brachytherapy for prostate cancer.
Yes, this is a prime example of interstitial brachytherapy, where radioactive sources are left permanently in the patient's tissue. It's a very effective treatment option for select prostate cancer patients, usually those with localized low-risk disease.
And the sources used are those tiny encapsulated seeds we hear about. What are the common isotopes used in those seeds?
The two most common isotopes you'll encounter are iodine-125 and palladium-103.
Iodine and palladium.
Right. They're encased in small titanium capsules, maybe the size of a grain of rice, roughly. This encapsulation is critical. It seals the radioactive material inside, preventing it from leaking out into the body.
And they have different physical properties, particularly their half-lives, right? How do they compare?
Yes, and this is a key difference that influences clinical practice and potentially radiobiology. Iodine-125 has a half-life of approximately 60 days, about 2 months.
Okay, 60 days for iodine.
Palladium-103 has a significantly shorter half-life, only around 17 days.
17 days versus 60 days, that's a big difference.
It is. So if both are prescribed to deliver, say, 145 gray total dose over their entire radioactive lifetime,
Yeah.
the palladium-103 is going to deliver that dose much, much faster initially because of that shorter half-life. More decays are happening per unit time early on.
Right, the initial dose rate is higher with palladium.
Exactly. A shorter half-life means the rate of radioactive decay, and thus the initial dose rate, is higher for the same total activity or prescribed dose. This difference in dose rate profile, a faster initial delivery with palladium-103 versus a more prolonged, slower delivery with iodine-125, is thought to have potential radiobiological implications.
How so?
Well-
Does faster or slower matter biologically?
Well, the thinking goes like this. Late-responding normal tissues, like the rectum or bladder, which turn over slowly, are generally thought to tolerate LDR better than HDR because they have more time for repair of sublethal damage during the long-dose delivery.
Okay, slow deliveries may be gentler on normal tissues.
Potentially, yes. Now, prostate cancer cells themselves are thought to have a low alpha-beta ratio, which implies they're relatively sensitive to the dose per fraction and potentially to the overall dose rate. This might make them particularly well-suited to LDR delivery in general. But the optimal dose rate within the LDR spectrum is faster LDR like palladium better or slower LDR like iodine. That's still debated and may influence the choice of isotope based on tumor characteristics or physician preference. It's an area of ongoing research and discussion.
Interesting. So the technique itself, it involves placing these seeds throughout the prostate gland using needles. How is this procedure guided? How do they know where the needles are going?
It's typically performed under ultrasound guidance, specifically transrectal ultrasound, or TRUS. You'll often hear it pronounced TRUS.
TRUS? Okay.
The TRUS probe is inserted into the rectum and provides real-time cross-sectional images of the prostate gland. This allows the physician to precisely guide the implantation needles through a template grid and visualize the placement of each seed as it's deposited from the needle tip.
So you can see the prostate and the seeds going in live.
Yes, you see the gland and the hyperechoic signal from the needles and seeds. And is the planning deciding where each seed goes done before the procedure or during? It can be done either way, or often a combination. Frequently, a pre-plan is developed based on a prior prostate volume study using TRUS or sometimes MRI, where the target volume, the prostate maybe with a margin, and critical structures like the urethra, bladder, and rectum are contoured.
Okay, so you have a map beforehand.
Right. Then, during the procedure, this pre-plan is adapted based on the real-time images, or sometimes a complete real-time plan is generated right there in the operating room based on the live TRUS images as the seeds are being implanted. The goal, either way, is to ensure the entire prostate volume is adequately covered by the prescription dose.
And what are the typical prescription doses for I-125 and PD-103 when used as monotherapy, meaning seeds alone?
Common prescriptions aim for a minimum peripheral dose, basically ensuring the edge of the prostate gets enough dose. For iodine-125 monotherapy, a typical prescription is 145 gray.
145 GA for iodine.
Yes. For palladium-103, because of the faster dose rate and potentially slightly different radiobiology, it's often prescribed slightly lower, maybe around 125 gray.
125 G for palladium?
These are the total doses delivered over the lifetime of the sources as they decay away.
And just as critical as covering the target prostate is sparing the nearby organs at risk, right? That must be a major focus of the planning.
Absolutely vital. The urethra runs right through the middle of the prostate, the rectum is immediately posterior just behind it, and the bladder sits right on top, superiorly.
Tight quarters.
Very tight. So strict dose constraints are applied to minimize dose to these OARs to reduce the risk of side effects like urinary problems, irritation, obstruction, rectal irritation or bleeding, or bladder symptoms like urgency or frequency.
How do they manage that, sparing things so close?
Modern treatment planning software uses sophisticated optimization algorithms. These algorithms help determine the optimal number of seeds, their individual strengths, sometimes slightly different strength seeds are used, and their precise 3D positions to best meet both the target coverage goals, like getting a 45G to the prostate, and the OAR constraints simultaneously. It's a complex balancing act.
Okay. After the seeds are implanted, the procedure's done, the patient goes home. There's a crucial follow-up step called post-implant dosimetry. What's the purpose of this? Why do it?
Post-implant dosimetry is essentially a quality assurance step. It's done to verify that the treatment that was actually delivered matches the treatment plan, or at least meets acceptable clinical standards. It's an evaluation of the actual dose distribution achieved based on the actual final seed positions in the patient's anatomy.
Checking your work, basically.
Exactly. Did we achieve what we set out to achieve?
And why is it typically performed about a month after the procedure? Why wait?
That timing is important. The implantation procedure itself, sticking needles into the prostate, causes some temporary swelling or edema in the prostate tissue.
Makes sense.
This swelling can temporarily displace the seeds or alter their relative positions slightly. Waiting about 1 month allows this initial edema to subside, so the imaging captures the seeds in their more settled, long-term positions within the prostate volume. This gives a more accurate picture of the dose distribution the patient will actually receive over the long term.
Okay, let the swelling go down. What kind of imaging is used for this post-implant check?
Usually it's a CT scan. Sometimes this CT scan is fused with a pre-implant MRI scan if one was done, because MRI can sometimes help define the prostate contours, the outline of the gland, more accurately than CT alone, especially the apex and base.
Okay, I see too. Maybe with MRI fusion. And what are the key metrics we evaluate on that post-implant scan? What numbers are we looking for?
We contour the prostate, the urethra, rectum, and bladder on the post-implant CT scan. The planning system identifies the location of all the seeds. Then it calculates the 3D dose distribution based on those actual seed locations. Key metrics reported for the prostate target volume typically include V100 and D90.
V100 and D90. Can you break those down? What do they mean?
Sure. V100 is the percentage volume of the contoured prostate that received at least 100% of the prescribed dose. So if the prescription was 145G, V100 is the fraction of the prostate getting 145G or more.
Okay, volume covered by the prescription dose.
Right. A high V100 may be greater than 90 or 95% depending on the institution's goals, indicates good coverage of the prostate volume by the prescription isodose line. D90 is the minimum dose received by 90% of the prostate volume.
Dose received by 90% of the volume. How is that different?
Think of it this way. V100 tells you how much of the prostate got the dose. D90 tells you how well the bulk of the prostate was dosed. D90 is often considered a better indicator of potential cold spots within the target volume. A high D90, ideally close to or exceeding the prescription dose, indicates that most of the prostate volume received at least the prescription dose, Even in the potentially colder regions, you don't have large areas getting significantly underdosed.
So V100 is about the overall volume covered. D90 is more about the minimum dose within the effectively covered volume, avoiding cold spots.
Essentially, yes. A high D90 is often seen as more critical for ensuring local control, making sure that the vast majority of the tumor-bearing volume gets the minimum necessary dose. We also evaluate OAR doses using DVHs from this post-implant plan.
What kind of OAR metrics?
For example, looking at the urethral dose, maybe V150 or V200, the volume of the urethra receiving 150% or 200% of the prescription dose to assess the risk of urethral side effects like stricture. And similar metrics for the rectum and bladder, like D, 2 cubic centimeters, the dose to the hottest 2 cc, or maybe the volume receiving 100% of the prescription, V100 for rectum bladder, to try and limit toxicity. Post-implant dosimetry is vital for quality assurance and for correlating clinical outcomes with the actual delivered dose over time.
Makes sense. Quality control is key. This brings us to a really critical concept we've touched on several times but needs a dedicated look: dose rate effects. The rate at which dose is delivered has major radiobiological implications, doesn't it?
It absolutely does. This is a fundamental concept in radiation biology and therapy. The biological effect of radiation is heavily dependent not just on the total dose given, but on how that dose is fractionated or delivered over time. It's not just how much, but how fast.
Why does the speed matter so much biologically?
Different dose rates allow different amounts of time for biological repair processes to occur during the irradiation itself. Cells are constantly trying to repair radiation-induced DNA damage. If the dose comes in slowly, there's more time for that repair to happen concurrently with the damage being inflicted. If it comes in fast, the damage overwhelms the repair mechanisms temporarily.
Okay. Let's define the main categories then. Low dose rate, high dose rate, and maybe pulse dose rate. What are the typical dose rate ranges for these?
Okay. Low dose rate, or LDR, brachytherapy, is generally defined as delivering dose at a rate between 0.4 gray per hour and 2 gray per hour. 1/4, 2 gray.
0.4 to 2 gray per hour. That sounds pretty slow.
It is a very slow, continuous, or near-continuous delivery. Think of the historical gin implants lasting several days, or the permanent prostate seeds decaying over months.
Right. And the implication of that slow rate.
Because the dose is delivered so slowly, over many hours or even days for temporary implants, normal tissues especially have significant time to repair radiation-induced sublethal damage during the treatment itself. This continuous repair occurring simultaneously with irradiation is a hallmark of LDR radiobiology.
Why is that good?
This differential repair capacity, the idea that slowly proliferating normal tissues might repair better during prolonged exposure than faster proliferating tumor cells, can potentially lead to a favorable therapeutic ratio. More tumor kill for less normal tissue damage.
Makes sense. The downside is the logistics.
Exactly. Logistically, as we discussed with GIN LDR, it often requires prolonged patient immobilization and hospitalization, with associated radiation safety measures for staff and visitors.
Okay, LDR slow, allows repair during treatment, maybe better therapeutic ratio, logistically complex. Contrast that with high dose rate, or HDR. What's the rate there?
HDR is defined by a dose rate greater than 12 gray per hour, 12 GR, and often it's much higher than that, hundreds of grays per hour right near the source.
Wow, 12 grays per hour minimum. That's way faster than LDR's 2 grays per hour maximum.
Orders of magnitude faster. We're talking about delivering a fraction of treatment in minutes rather than hours or days.
Much, much faster. And what are the radiobiological implications of delivering the dose that quickly?
Because the dose for a single fraction is delivered so rapidly, there is very little time for significant repair of sublethal damage to occur during the actual dose delivery of that fraction. The damage happens too fast.
So repair doesn't happen during the minutes of the treatment?
Essentially, no significant repair during the beam on time. Repair primarily happens between fractions in the hours between one HDR treatment and the next. This is the basis of conventional fractionated external beam radiotherapy as well, giving time between fractions for normal tissues to recover.
So HDR acts more like external beam in that sense.
Radiobiologically, yes. A single HDR fraction delivered in minutes behaves more like a single large dose per fraction in external beam. This is why HDR treatments are always delivered in multiple fractions, typically spaced hours or days apart, similar to external beam schedules. The goal is to exploit the differential repair between fractions that hopefully favors normal tissue recovery over tumor recovery.
And the logistics of HDR.
Logistically, HDR using remote afterloaders is very convenient. Usually outpatient treatment, quick setup and delivery times. Excellent patient immobilization is possible during the short treatment, and crucially, no radiation exposure to staff during the actual treatment delivery.
Okay, so LDR allows repair during the long delivery. HDR forces repair to happen between the short, intense fractions. What about pulse dose rate or PDR? That sounds like a hybrid.
It is, in a way. PDR is an attempt to mimic the radiobiological advantages of LDR, specifically the repair during treatment, while using the convenient and safe HDR technology.
How does it work?
It uses an HDR remote actiloader unit to deliver the total intended dose in a series of short, high-dose rate pulses, typically delivered perhaps once every hour.
So the source comes out for a few minutes, delivers a bit of dose, goes back into the safe, waits an hour, then comes out again for another pulse.
Precisely. The dose rate during each individual pulse is high, just like standard HDR. But the average dose rate over the entire treatment period, including all the time the source spends retracted between pulses, is low. It typically falls into the LDR range, maybe around 0.5 to 1 gray per hour, 0.51 Gerard-year.
So the average rate is low, even though the instantaneous rate is high. What's the goal there, radiobiologically?
The radiobiological hypothesis, or hope, is that by delivering the dose in pulses with significant quiet breaks in between, like that hour off, you allow normal tissues time to repair damage in between each pulse, similar to how they repair during continuous LDR delivery.
Trying to get the LDR repair benefit.
Exactly. While simultaneously gaining the logistical advantages of HDR remote after loading, like no manual source handling, no staff exposure during delivery, precise computer control over source positioning and timing.
It sounds like a clever attempt to combine the best of both worlds. Is it commonly used?
It's used in some centers, particularly in Europe, for certain sites like gynecological cancers. But it hasn't completely replaced either LDR or standard fractionated HDR worldwide.
Why not? What are the challenges?
Well, it still requires the ability to keep the patient accurately set up and immobilized with the applicator in place for the entire treatment duration, which might still be a day or two, similar to LDR hospitalization, even if the radiation precautions are less stringent between pulses. And the clinical evidence comparing PDR directly to modern HDR or LDR outcomes is still evolving for many sites.
Okay, so the choice between LDR, HDR, and PDR isn't always clear-cut.
Definitely not. It depends heavily on the tumor site, the available clinical evidence for that site, the technology and resources available at the institution, institutional preference and experience, the specific radiobiological rationale for that particular tumor and surrounding OARs, and patient factors like their overall health and ability to tolerate prolonged immobilization if needed. It's a complex decision.
This has been incredibly helpful in connecting the dots from the fundamental sources and physics all the way to the clinical delivery and the different ways we do it. Why is having this detailed understanding of techniques, historical systems, dose points, and dose rates so fundamentally important for someone learning radiation oncology? Why wade through all this detail?
Because it's the bedrock. It's the foundation for planning and delivering brachytherapy safely and effectively. Without this understanding, you're just following recipes without knowing why. This knowledge directly influences your clinical decision-making at multiple levels every day if you do brachytherapy.
Give us some examples. How does this impact actual decisions a clinician makes?
Okay, well, first and foremost, the choice of technique. Based on the patient's anatomy and tumor characteristics, can you even treat this patient with brachytherapy? If so, is it amenable to an intracavitary approach using standard applicators, like for cervical cancer?
Yeah.
Or does the tumor shape or location demand an interstitial implant?
Right. Cavity versus needles.
Exactly. And if it's interstitial, are permanent seeds suitable, which implies LDR? Or do you need a temporary implant? And if temporary, are you going to choose LDR, HDR, or PDR? All these decisions depend on the tumor site, size, location relative to critical OARs, and the desired dose distribution shape, which ties directly back to understanding source properties, dose fall-off, and dose rate effects.
Okay, choosing the whole approach. What else?
Then, once you've picked the general technique, it guides the applicator selection or implant design. For gynecological cases, selecting the correct tandem length and ovoid size isn't trivial. It's critical because it directly determines the geometric relationship, and thus the dose relationship between point A, point B, the target volume, and the nearby bladder and rectum. Choosing the wrong size applicator can compromise coverage or overdose OARs.
Right, the geometry matters.
Hugely. For interstitial implants, even when using modern inverse planning software, the principles of source arrangement, like aiming for relatively uniform coverage or understanding how steep dose gradients are created near sources, are still informed by the historical systems like Manchester or Paris. You need to know why certain source arrangements are generally preferred or avoided to guide the planning process and troubleshoot suboptimal plans. The computer needs smart inputs.
That makes sense. The history informs the modern tools.
Absolutely. And then comes plan evaluation. Knowing which metrics are relevant and standard for which specific brachytherapy application is non-negotiable, you have to speak the language.
Different metrics for different sites.
Yes. You need to know that for a classic LDR gen plan, evaluating point A and B doses provides essential historical context and quick geometric check, but evaluating the OER DVHs, like D2CC for bladder and rectum, is paramount for modern safety standards. For prostate seeds, you must understand V100 and D90 as the key indicators of target coverage, along with OER DVH constraints like maybe urethral, V150, or rectal D 2 cubic centimeters. Each application has its established set of evaluation criteria you need to know.
So you need to know what to look for on the plan report.
Precisely. And finally, understanding these historical concepts, the points, the systems, is essential for interpreting the vast brachytherapy literature. So much foundational clinical trial data and outcome studies in brachytherapy, particularly older landmark studies, report dose based on point A or describe interstitial implants in terms of Manchester or Quimby rules.
Right, you can't understand the old papers without it.
Exactly. Without understanding what these terms mean and the kind of dose distributions they typically imply, you can't accurately interpret the reported outcomes, understand the evolution of the practice, or apply that historical knowledge appropriately to your modern practice. It connects the past to the present.
It really provides that crucial historical context and helps you see the evolution of how we approach brachytherapy planning and evaluation over time.
That's a great way to put it.
Okay, let's do a quick review blitz then, like a mini board review session, hitting some of the absolute key concepts we discussed. Ready?
Fire away. Let's consolidate some of these points. Good idea.
First, the most basic difference: intracavitary versus interstitial brachytherapy. In a nutshell, what's the core distinction?
Intracavitary. Sources go inside natural body cavities using applicators. Think gin tandem and ovoids. Interstitial. Sources go directly into the tissue itself. Think prostate seeds or breast implant catheters.
Perfect. Now, those two key gynecological dose points from ICRU 38, point A and point B. Give me the quick geometric definition and, crucially, tell us which one moves with the applicator versus which one is fixed relative to the patient's anatomy.
Okay. Point A defined 2 centimeters superior and 2 centimeters lateral from the cervical os or the tandem flange. It's meant to represent dose to the perimetrium near the ureter, and it moves with the applicator.
Moves with applicator. Got it. Point B.
Point B defined 3 centimeters lateral to point A, which puts it 5 centimeters total lateral from the patient's midline at the same superior-inferior level as point A. It represents dose near the pelvic sidewall and obturator nodes, and it is considered fixed relative to the patient's pelvis.
Fixed to the pelvis. Excellent distinction. Okay, moving to interstitial systems. Give me the name, the primary goal, uniform dose versus minimum dose versus something else, and the method, uniform versus non-uniform source loading, for the three main historical systems we discussed: Manchester, Quimby, and Paris. Use the mnemonics if they help.
All right. Manchester or Patterson-Parker, that's MNU. Goal. Uniform dose distribution, ideally plus minus 10%. Method. Non-uniform source loading, with stronger sources at the periphery's rind to compensate for edge effects.
MNU. Got it. Next.
Quimby, that's QUH. Goal. Achieve a specified minimum dose throughout the volume. Method. Uniform source loading, which results in a hot spot in the center.
QH.
Okay, last one.
Air system. PUB. Developed for parallel line splanes, often wires or catheters. Method. Uniform source loading along the parallel lines. Prescription goal method. Dose specified as 85% of the basal dose, which is calculated midway between the lines.
Fantastic. MNU-QUH-PUB. It works. All right, permanent prostate seed implants. What dose rate classification is this fundamentally?
Prostate seeds are a classic example of low dose rate LDR, permanent implants.
LDR. What are the two most common isotopes used, and critically, which one delivers its dose faster initially due to its shorter half-life? The two common isotopes are iodine-125, which has about a 60-day half-life, and palladium-103, which has about a 17-day half-life. Because palladium-103 has the significantly shorter half-life, it delivers its dose much faster initially.
Palladium is faster. Okay. And for evaluating the success of those prostate seed implants, What are two key target coverage metrics we look at on the post-implant dosimetry CT scan? And briefly, what do they represent?
The two big ones are V100 and D90. V100 is the percentage volume of the prostate receiving 100% or more of the prescription dose. It measures how much the target volume is covered by the desired dose level.
Okay, V100 for volume.
And D90 is the minimum dose received by 90% of the prostate volume. It's a measure of dose adequacy in the potentially colder regions of the target, indicating how well the bulk of the prostate is dosed, aiming to minimize significant cold spots.
D90 for dose adequacy. Great. Finally, let's recap the dose rates. Give me the rough dose rate ranges that define LDR, HDR, and the average rate for PDR, and the primary radiobiological concept associated with each in terms of when significant repair of sublethal damage can occur.
Okay, LDR, roughly 0.4 to 2 gray per hour. The key radiobiology is allowing significant normal tissue repair during the prolonged continuous delivery.
Repair during delivery for LDR, HDR?
HDR, greater than 12 grays per hour. Delivery is very rapid, so there's minimal repair during the fraction itself. Repair primarily occurs between the multiple fractions.
Repair between fractions for HDR, PDR.
PDR aims for an average dose rate similar to LDR, maybe 0.5 to 1 gray per hour, delivered via short pulses from an HDR unit. The goal is to mimic LDR repair advantages by allowing time for repair between the hourly pulses.
Repair between pulses for PDR. Fantastic review. That really helps consolidate some key high-yield concepts. It underscores how understanding these different facets, the technique, the historical planning logic, the dose points, the evaluation metrics, and the dose rate implications is absolutely critical for anyone involved in planning or delivering brachytherapy.
It really is. It provides the essential framework. Whether you're doing manual planning in some situations or interpreting and guiding the output of modern computer-optimized plans, this knowledge is foundational. It connects the physics principles you learned back in the classroom to the practical realities of treating patients safely and effectively.
And if you want to review this information further or find additional resources like practice questions or more detailed notes on these topics, you can check out RadOncSmartLearn.com. That's RadOnc.smartlearn.com.
Yeah, that site is specifically designed to help residents and physicists solidify this kind of material, especially when preparing for exams or just wanting to deepen their clinical physics understanding. Lots of good stuff there.
So we've taken a pretty thorough look today at brachytherapy applications and planning concepts. We covered the core distinction between intracavitary and interstitial approaches.
Inside cavities versus inside tissue.
We explored the logic behind those historical interstitial planning systems, Manchester, Quimby, and Paris, and why they matter even now.
The MNU, QUH, PUB.
Exactly. We drilled into the significance of key dose points like ICRU 38's point A and B for GIN brachytherapy, what they mean and how they behave.
The moving point versus the fixed point.
We discussed the specifics of LDR prostate seed implants, the isotopes, the technique, and how we evaluate them with V100 and D90.
A very common and important application.
And we compared the radiobiological and logistical differences, the pros and cons of the different dose rates, LDR, HDR, and PDR.
It's definitely a lot of information packed in there, but mastering these concepts is truly fundamental to delivering safe, effective, and high-quality brachytherapy treatments. You can't really do modern brachy well without understanding this foundation.
It does make you pause and think, though, about the future. With the power of modern 3D imaging like MRI integrated into planning and treatment planning systems that allow true 3D optimization based on dose-volume histogram objectives for targets and OARs, how does all this historical knowledge about specific points like Point A and systems like Manchester really integrate with that? Is it still relevant?
That is the key question, isn't it? It's the ongoing evolution of the field. We have these incredibly precise imaging and optimization tools now, far beyond what Patterson-Parker or Quimby could have imagined. We can contour the ureter directly. We can shape dose with inverse planning.
So do we still need point A if we can see the ureter? Do we need Manchester principles if the computer optimizes the dwell times in an HDR breast implant?
I think the answer is nuanced. Yes, our primary evaluation relies on VBHs and 3D dose distributions now. But the principles derived from these historical systems of points still provide invaluable context. They act as quality assurance checks. Does the point A dose look reasonable for this type of plan? Does the overall source arrangement make sense based on Paris principles? They provide a link to decades of clinical experience and outcomes reported using those older metrics. It's about marrying the foundational understanding, the why, with the powerful technological capability we have today. It helps ensure the computer isn't giving us something biologically nonsensical, even if it looks mathematically optimal on paper.
A good thought to carry forward, balancing the history, the principles, and the modern technology.
Absolutely. It's about using all the tools in the toolbox, including the historical ones.
Well, that's all for this exploration into the applications and planning concepts of brachytherapy. We hope it provided some clarity and valuable insights into this complex but vital part of radiation oncology.
Thanks for joining us. Keep exploring, keep questioning, and keep learning.
And remember, you can complete practice oral boards and find more resources at radoncsmartlearn.com. Thanks for tuning in.